from all those who are coming from the Philippines. This is Aliyah Evangelista from the Asia eHealth Information Network. Welcome to our AeHIN Hour, and this afternoon we are going to have a special AeHIN Hour for our topic, the nursing contribution to health information worldwide. So some announcements before we start our session. The things we have to remember, first is our platform. Second is our ways to participate. Thirdly are the program details. And fourthly, our email feedback. So we're now using our Cisco WebEx Event Center, and our room number is 866-950-092. Please take note of our meeting number and password UK123 because you will be using this if you will log out and rejoin our session. Secondly, your mic will be mute for the rest of our meeting, but you can actively participate by sending your feedback to our session, chatting your response, and posting your question. You can send your feedback by clicking the feedback button on the right side of your screen below the participants window. That's the icon with a dialog balloon with the check icon inside. On the drop down, you can respond by a yes or no. Say the presentation is too fast or too slow, and you can also appreciate by sending your virtual applause and laughter. You can chat your response by typing your message to the speaker, or in this case, our panelist, and to the host, or both inside to the meeting room. But I just want to warn you, you could only send your chat to me as the host and to the presenter, Professor Hardiker, and you cannot talk to all the attendees. You can post your question in our Q&A box located in the lower right panel of your screen. You could just type your question directly to either me or to both of us in this session. For our program details, this session will run for 45 minutes to 1 hour, and you can send your questions to our Q&A box as it arises from your hand. We highly encourage everyone to be active in our chat box and in our Q&A box so that we will all be prepared during the Q&A session at the middle and at the end of this AeHIN Hour. And lastly, please check your email because I will be sending an email feedback form to you so that we could evaluate our AeHIN Hour for this afternoon. So those are the 4 things we have to remember: our platform, our program details, our ways to participate, and feedback email. So our speaker for this afternoon is Professor Nick Hardiker, who is a professor of nursing and health informatics and associate head for Research and Innovation of the University of Salford School of Nursing, Midwifery, and Social Work. Professor Nick has a background in nursing and has a bachelor's, master's, and doctoral degrees in computer science from the University of Manchester, UK. He has nearly 20 years of experience of theoretical and applied research in health informatics with a particular focus on health records and terminologies. Nick holds an adjunct position of professor at the University of Colorado, Denver, USA. He has also published widely and is asked regularly to speak conferences and seminars. He is director of the International Council of Nurses eHealth program, editor-in-chief of Informatics for Health and Social Care, a member of national and international standards bodies and think tanks, and regularly provides advice to organizations such as the UK Department of Health on informatics issues. Thank you very much for being with us this afternoon. I would like to welcome you for our session on the nursing contribution to health information worldwide by Professor Nick Hardiker. Hi, Professor Nick. You are now being adjusted as the presenter of this webinar.
Okay, thank you very much. Good afternoon, everybody. I assume you can see my slides okay now. So My name's Nick Hardiker, as given in the introduction, and yes, I am a professor at the University of Salford in the UK, but for the focus of this talk, I'll be talking about principally about the International Council of Nurses and my work with them as director of the eHealth program. So in a kind of overview and summary of the talk, I'll be talking about what's widely seen as a global healthcare crisis related specifically to nursing and the numbers of nurses. And then I'll focus the bulk of my talk around technological solutions to the crisis, focusing specifically on the eHealth program of the International Council of Nurses, and looking in particular, because this is about information, about one of our products and programs, the International Classification for Nursing Practice. So just by way of introduction, the International Council of Nurses, if you don't know, is a federation of over 130 national nurses associations. And we collectively represent more than 16 million nurses worldwide through those national nurses associations. We're the oldest international health professional organisation. We're operated by nurses and we're for nursing. So our purpose is to represent nursing worldwide, advancing the profession and influencing health policy. This is a picture taken in Geneva where ICN, the International Council of Nurses, is headquartered. I don't work there. I work in Salford in the north of England. Here's a picture of Salford. This was taken some time ago. But Salford it's always been a deprived area, a poor area. One commentator said that the workers of Salford live in dwellings in which cleanliness and comfort are impossible. You may know the name there, Friedrich Engels, who collaborated with Karl Marx on the Communist Manifesto. Much of the research underpinning the Communist Manifesto was done in the areas, in deprived areas in England, such as in Salford. This is what the city looks like now, or part of the city looks like now. We're home to what's become known as Media City. If you were standing where this picture was taken, you turned around, you'd see Manchester United football ground. And of course, in the interest of parity, I have to also now show Manchester City football ground. This is on the other side of the city, quite distant from Salford. So I mentioned Friedrich Engels, who was writing about 150 years ago. This, if you didn't know, is a picture of Florence Nightingale, also writing around that time, around 150 years ago. I see Florence Nightingale as the kind of grandmother of informatics, of eHealth. Certainly she's widely regarded as one of the founders of modern epidemiology. She wrote, 150 years ago, she wrote, "In attempting to arrive at the truth, I've applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purposes of comparison." What she wrote then, in many respects, still holds today in many areas of the world. Basically, what she was saying, that if we had better information, then we would have better healthcare. She also went on in Notes on Hospitals to present tables, data collection tables, which would provide a record of facts which would cover the total sick population, the number of cases, the average duration, mortality, etc. So these are things that are still current today. This is information that we still need today, that we would still like to gather today. Thinking a bit more recently, so another author wrote, "Today, the nursing shortage being what it is, every effort should be made to utilize our nurses to the utmost and not take their time with clerical work of no immediate value. I think many people would agree with this statement, and they did agree with it when it was written. Sorry about this. When it was written in 1953, so this is over 60 years ago. This was written, and it still holds today. So, thinking actually more recently, nurses have been involved in informatics for a long time. For over 50 years, they've been involved in informatics, doing research, making advances, and publishing. So here's an example of one piece of research that was done in 1975, which was to develop a computer program to assist the nursing process. Now, to put this into context, the nursing process, which is a decision-making model used within nursing, it was only formally introduced into the UK in 1977. So the work that was done in the United States actually predated the introduction of the nursing process. Unbelievably, the PC, the first personal computer, was only introduced in 1981. It's very interesting, this picture, this photograph of the computer. The only real piece of equipment missing is a mouse. Everything else, although it looks a little bit outdated, is still pretty much how we have things today, with a monitor, a box, a keyboard, and a printer. So I want to just talk about nursing shortage. This is the crisis I was talking about in my introduction. So the normal way of looking at the world is in this traditional map, which looks at the world in terms of area, land area. But there are other ways of looking at the world, and some smart people at a place called World Mapper have found a way of changing the nature of the world based on different criteria, so presenting the world not just in terms of geographical area, but also in terms of other pieces of information. So we can change the world by looking at it in terms of, for example, the proportion of cases of TB. And the world looks very different when we look at it from this perspective. So you can see that in terms of the proportion of cases of TB, there are some countries which are enlarged, and there are some countries which are really shrink to virtually nothing. So if you look at the United States of America, for example, it becomes very thin, whereas if you look at India, then this is full and much larger. Now we can look at the world from a different perspective in terms of the world as a proportion of nurses. And it's a very different picture again, almost the opposite of what we saw before. So the United States, for example, is much larger. We look over towards Japan, for example, that's much larger. Whereas looking at Africa in particular, that's gone very thin, just as the United States was when we were looking at tuberculosis. So if I just animate it, you can see the contrast between perhaps what's required and what's available. So that was the number of the proportion of TB. This is the proportion of nurses working in the different countries. So, in summary, there aren't enough nurses. The supply of nurses in low-income and high-income countries alike is not keeping pace with demand. In sub-Saharan Africa, for example, there's a shortfall of around 600,000 nurses, and out migration exacerbates the problem. So that's nurses leaving the country, perhaps for financial reasons, makes the problem worse. And there's a disparity. So the nurse to population ratios varies widely from less than 1 to 10,000. That's one nurse for 10,000 people, to more than one nurse for every 100 people. And what we know from what we've always known, but what we know from more recent research, is there's a link between adequate staffing levels and nurse education and positive care outcomes. Some of you may have seen, for example, a recent article in The Lancet published earlier this year, which was reporting on a study called RN Forecast. And what the study was looking at was whether differences in nurse-patient ratios and education affected mortality after routine surgery. And what it found, here's the results reported here. So basically, what it found, if we took two hospitals, for example, if we had in one hospital, we had 60% of the nurses with a bachelor's degree, and each of those nurses was caring for an average of 6 patients. And we compare that to a hospital where there are only 30% of nurses holding a bachelor's degree, and those nurses each was caring for an average of 8 patients, 2 patients more, then what we would find was a 30% higher mortality in the hospital with the less well-educated nurses who had a higher workload. So what can we do about that? We could put money into it. We could lobby governments, for example, for more nurses. We could make workforce policy interventions. The problem is, though, money won't help. If there aren't enough nurses, money can't help. Lobbying won't help. There are no people to become nurses, and workforce policy interventions will do little. Something we could do in terms of greater efficiency, but the numbers just don't add up. So one solution that we see within the eHealth program at ICN is eHealth itself. So using technology to help with the nursing crisis, as well as to improve care. But principally, it's ICN is very committed to equity and access, so a fairer access to people and greater equity in healthcare. So eHealth, I'm sure I don't need to go through the definitions of eHealth with you, but we follow the WHO, the World Health Organization, description of eHealth, which is a very broad description. Okay, I think I should be back online now. Sorry about that. So let me just backtrack a little. Basically what I was talking about was the nursing shortage, the impact of the nursing shortage being essentially more people die, and that the traditional ways of tackling the problem aren't appropriate because there simply aren't enough people to become nurses to solve the problem. So we see eHealth as being one of the solutions, using technology as being a solution for this crisis. So examples of eHealth, as you know, range from electronic patient records right the way through to social networking support groups and beyond. Round the corner, there are things that we can't even imagine, just as we didn't imagine the internet before it came, the World Wide Web before it came, social networking before it came. So in some years, just around the corner, there'll be new technologies, new forms of eHealth that we haven't yet imagined. So the eHealth program at ICN, the strategic aim of the program is to transform nursing through the visionary application of information and communication technology. And it's the transformation that's important, not the application of the information and communication technology. So we're interested in transforming nursing. Nursing has to change, and we think that we can use ICT to affect that change. The program itself has been over 20 years in the making, and it was formally announced at the conference, the ICN conference in Malta, 3 or 4 years ago. I found it quite important to kind of manage expectations around eHealth. You may have known within the UK in particular, we for some years have been working towards a national solution, a national information technology solution. As part of that process, it's been important to change people's hearts and minds and win over people. And so people's expectations have been raised very highly in terms of what they might imagine information and communication technology, eHealth or informatics might achieve. If we just backtrack a little and think about eLife, for example, just as we think of eHealth, we could characterize the things that we do, we take for granted now in terms of a kind of electronic paradigm. So we could think of banking, for example, e-banking, as the use of information and communication technology in banking. The same for shopping, the same for making travel arrangements, entertainment, and for social engagement. But I think, for eHealth, we have some fairly unrealistic expectations. If we think about commonly used technologies, so for example, ATMs or cash machines, they're very convenient, but they've not improved my financial status. I still go into debt every month. Before I get paid, I still go into debt. Similarly, I can get television, I can watch television programs whenever I want to, wherever I want to, but I still don't like particular genres of television programs. I don't like soap operas, and on-demand television, while it's convenient, doesn't help me like soap operas. Similarly, GPS systems, sat-navs in a car, I can get from A to B much easier without looking at maps, but it has not made me a better driver. My journeys aren't safer as a result of using the technology. And booking my holidays online hasn't made the sun shine when I've got there. It would be unrealistic to expect of that of a technology. It's convenient, but it doesn't make the sun shine. But the reality is I can't live without them now. I can't live without these technologies. I simply wouldn't know how to book a flight without going online. I've forgotten. Similarly with banking, I do my banking online. I very rarely go into a bank, into a physical bank. So my own vision is that eHealth systems are in routine use in a way that parallels other aspects of contemporary life. So the way that I do banking, the way that I book travel, I want eHealth systems in routine use, just the way that those other technologies are. From my own personal point of view, I've been researching around information and data for over 20 years, and I'd like data to be available and routinely used and exploited for the benefit of patients and for those caring for them. And I'd also, obviously, being a scientist, I'd like people to be actively working on improving things, advancing the art or the science of informatics. So really what I'd like, I think, is for the E to fall out of eHealth and for it just to be health. ICT used routinely within the context of health. I just wanted to, right now, I wanted to just pause for a minute and just see if there are any questions from participants, any burning questions that maybe couldn't wait, can't wait until the end. So okay. I'll just, yeah.
There's one question here from Dr. Mean Sambas from Cambodia. Please share us or maybe give us an article on computerized systems for nursing process later after the session. I think this is a request.
Okay, the computerization of the nursing process, so computerization of care planning. I will do this after the event.
All right. Another follow-up. Could you please explain more on eHealth for decision support system for nurses?
Yeah, I think the best thing I could do, probably in relation to that, is actually to provide another reference. There's work done. For example, Professor Dawn Dowding, who's recently moved to Columbia University to work with Suzanne Batten, she's done a great deal of work around computerized decision support for nursing. So perhaps the best thing I could do is to, well, you feel free to search on Professor Dowding on the internet, and I'll happily source an article in relation to that.
Okay, thank you for answering. Maybe we will have more questions at the end. So I think we could proceed at the moment. Just a request, Professor Hardiker, I received many chat from our chat box that they cannot hear your voice. I hope that you could speak slower this time for the second half of our session.
Okay. I apologize. I do speak quickly, and I'll try to speak slower, and I'll keep checking myself because I will speed up.
All right. Thank you so much. Okay.
So why would the International Council of Nurses be interested in eHealth? To the extent that we have a whole work program around eHealth. It's fairly obvious. There's a proliferation of information and communication technology. And because ICN informs and advocates for nursing and its members, it's important that it can inform and advocate in terms of information and communication technology. eHealth itself, or the use of ICT, threads through many of the existing ICN processes and products. And so it makes sense that we keep a keen focus on eHealth. And more importantly, most importantly, ICT, eHealth, informatics provides new opportunities, particularly around equity and improved access, which are things which are very important to the International Council of Nurses. So within the program, we have three main work streams: connecting nurses, the telenursing network, and the international classification for nursing practice. For completeness, I'll talk about all three work streams, focusing specifically on ICNP. Connecting Nurses is an online platform. It's a forum for health professionals from around the world to share their ideas, their advice, and any initiatives or innovations. It's supported by Sanofi, a French pharmaceutical company. There are two aspects to Connecting Nurses. The first is a platform called Information Therapy, which is a patient education service. Nurses and midwives can use the platform to share high-quality resources that they can then pass on to their patients. So it's a way of finding good material that can then be shared amongst the community. And it has a dedicated social media style platform to affect this. Any nurses can sign up to Information Therapy and participate. can draw resources from the platform and contribute resources to the platform. The second aspect of connecting nurses is a contest called Care Challenge, and Care Challenge is it's a competition to highlight nursing innovations and to help to translate those into practice. So this year there have been 2 winning entries, and both of the authors. There's no financial prize, but both authors have chosen to have a video produced to display their project as the means of supporting and connecting nurses. So what this does, not only does it raise the profile of the innovation, but it also helps to implement it on a wider level. Here's an example of one of the winners this year, which was a fairly simple initiative to use Skype to reduce loneliness and social isolation in residents in long-term care facilities in Canada. The second work stream within the program is the telenursing network, the ICN telenursing network, which again, it's a resource, a network for sharing knowledge and expertise specifically around telehealth and telecare. And there's strong links between the telenursing network and the International Society for Telemedicine and eHealth. The network was launched 5 years ago, and it has, I think now it has over 300 members in over 65 countries. Membership's open to all, and like any network, its success depends on the members themselves and the participation of members. So the final work stream, and this is what I'll talk about for the remainder of my talk, is the International Classification for Nursing Practice. This has been supported by ICN since 1989. So this was the very start of the seed of the ICN eHealth program. It was in 1989. And in fact, this year we celebrate our 25th anniversary for the International Classification for Nursing Practice. It's a standardized terminology. It's used to represent statements around that describe nursing diagnoses, nursing interventions, and patient-sensitive nursing outcomes. There are several nursing terminologies. I'm not saying that ICNP is better than others, is different to others, and I'll just explain some of the features of ICNP. First of all, we comply with international standards, and ICN has been heavily involved in both the original standard and the revision of the standard around a categorical structure for nursing terminologies. We ensure that ICNP is fully compliant with that standard. We have a very rigorous quality improvement process which is associated with the biennial release. So we commit to release ICNP every 2 years at ICN Congress or conference. That predictable timetable is important for developers who need to think about migrating their system and can plan that absolutely into their own evolution. There's a formal infrastructure, which I will go into some detail, but the formal infrastructure, ICNP is built on the web ontology language, which is a formal representational language, which is computable. And this is generally it's hidden from users, but what it allows is that we can facilitate cross-mapping, and we can allow output in multiple formats. And I'm hoping to be able to show this to you shortly. We have even though it is complicated underneath, we have got an ongoing focus on pre-formed or pre-coordinated statements. So it's actually a compositional language, but we focus very much for the users on pre-formed statements. That means statements that regular expressions that nurses might use in practice. We also package those statements into an increasing number of catalogues, which are essentially they're subsets of the ICNP, which are tailored for specific purposes, for specific conditions or specific settings. ICNP is available in 15 different languages currently, and that number of languages is growing. It's the only nursing terminology that's accredited as a related classification in the WHO family of international classifications. So you'll be aware that there's a core of the core of the family is ICD, ICF, and the emerging international classifications for health interventions, ICHI. ICNP sits outside of that core family, but is classified as a related classification. It's recognised by a number of national nurses associations, and for example, Portugal, the National Nurses Association there recognises it, but also it's mandated by the Portuguese government in any public procurements of nursing systems. And we have harmonisation agreements with the International Health Terminology Standards Development Organisation, which oversees the development and distribution of SNOMED CT, and with Hardiker, who oversee the development of the clinical care classification. And these agreements, what they've allowed us to do is to develop equivalence tables of equivalence between ICNP and SNOMED CT, and between ICNP and CCC, the clinical care classification. And this is, as the director, I think this is very important because many people prefer to use different terminologies. Some people prefer ICNP as their terminology, but we recognise that SNOMED CT, for example, is gaining ground. It's becoming adopted in more and more countries, and is likely to form part of a more global health informatics infrastructure. And I'm determined that nurses are not disenfranchised from that infrastructure, and so we've been very committed to providing a way of mapping from ICNP content through to the more general SNOMED CT content. So ICNP is big and growing. The structure of ICNP is fairly stable. The difference between different releases is the size, and so ICNP continues to grow, but doesn't change in terms of its overall structure. So we currently have nearly 800 diagnosis and outcome statements, and we have over 800 intervention statements. We try to make ICNP as available as possible to people. So there is an online browser. We're currently in the process of we've commissioned a new browser which has a much cleaner, simpler interface. And this will be a multilingual browser. People will be able to view ICNP in different languages. So in terms of making ICNP available and making it implementable, we encourage, we support different countries, different groups to use ICNP at the point of care. So as I mentioned before, there's a national endorsement within Portugal. An increasing number of countries are also endorsing ICNP to greater or lesser extent. So the National Nurses Association of Norway, Canada, and to some extent the USA have acknowledged ICNP as appropriate for use in nursing systems. And then we have a number of commercial agreements with software suppliers in Norway, USA, and Portugal. There is no financial implications for research and development concerning ICNP, but when software suppliers start making money out of having ICNP, then of course we ask for some contribution back to ICN. We're continuing with catalogue development. As I mentioned before, catalogues are subsets of ICNP, and we're continuing with the translation activity in order to increase the reach of ICNP. We have individual and collaborative research and development projects going on all over the world. And we have a number of accredited centres for ICNP research and development. So these are accredited by ICN to conduct research and development around ICNP. These are the centres that we currently have, and you can see they cover a wide range of activities, wide geographical spread as well. Some are around translation of ICNP. Some, for example, in Portugal, are around improving the quality of care. In Chile, it's about ICNP and family nursing with a view to kind of developing catalogues or subsets that are relevant to family nursing. So I just wanted, I threatened or mentioned before that I will talk about some of the technical aspects of ICNP and why we chose to go with a formal definitional language as being the infrastructure for ICNP. And I just wanted to explain why we took that decision. So if we think about the way that most information is moved around in healthcare, we use natural language, either speech or we use text, and that's how we manage most information. It's the main currency for clinical information, unsurprisingly, because it's very expressive and it's very familiar to us. It comes naturally, but the flexibility and the expressiveness makes it complex and difficult to analyse, manipulate, and reuse for some of the purposes that we'd like within healthcare. What the upshot of that is one easy way of solving that is to predetermine what people might want to say. So to develop a standardized terminology or a classification. And what's happened over recent years is that there's been a proliferation of terminology. The reasons for this is that healthcare is very big and it's very complicated. There are many people doing many different things, and healthcare continually advances, continually changes. And to make matters worse, for a particular purpose, for a specific purpose, it's very easy to build a terminology. So people tend to build their own terminology rather than a more challenging task of adapting somebody else's terminology for your own purposes. So terminology are getting bigger, they're getting more numerous, and they're getting more complex. Here's some examples of terminologies within the Unified Medical Language System, which is a repository of terminologies within the United States National Library of Medicine. Here's some more, and some more, and some more, and some more. So you can see there's a problem. This is all about healthcare. There are some differences between the terminologies, but there's an awful lot of common ground. Healthcare is healthcare, and if you're trying to describe healthcare, there's a limited amount of variation in those descriptions. So what we have is multiple terminologies being used in different sites. So the coloured balls in this diagram would represent individual terminologies being used at different, in this case, hospitals. While just holding on this slide for a second, the use of a standardised terminology brings benefits in itself, regardless of its ability to share information between units. So a particular unit will get benefit out of using a standardised terminology. But when we want to look at things a bit more globally, it's the sharing of information that's important so that we can make comparisons. So what we're left with is diverse overlapping systems. As I mentioned, there's little variation between different terminologies in terms of the content. Healthcare is healthcare. And so we've got three expressions here which are related in some way. In fact, two of them are probably equivalent. They're probably synonyms. So one solution would be just to throw them all out and throw away all of the terminologies and just have one terminology. People have tried to do this, and it appears that it's impossible just to have one single terminology. So another solution would be to look at the terminologies and produce a mapping between those terminologies. So look where there is equivalence, for example, between endotracheal extubation and removing endotracheal tube, and make a mapping, make a connection, direct connection between them manually. This is fine with a limited number of concepts within a limited number of terminologies. It may be possible. You can see that it's fairly complicated because we have to make mappings between each of the terminologies to each of the other terminologies. But then also, when you want to make a change to one of the terminologies, there's a knock-on effect to all of the other terminologies. And so the mappings themselves to all the other terminologies have to be re-looked at, revisited. So the task becomes impossible. So the current thinking is to have a kind of black box or an interlingua in the middle. We call those reference terminologies. So we can now make a change into, for example, the white terminology and leave the black box to sort out the problems with the other terminologies, the mappings to the other terminologies. So examples of terminologies with reference properties like this is no medical terms, which I mentioned, and the International Classification for Nursing Practice. And what the need for a formal infrastructure, the reason for a formal infrastructure of representation language is so that we can, there are two concepts here, there's acute pain and pain that comes on suddenly. They mean the same thing, essentially, that it's just being expressed in different ways. And what we can do is use the reference terminology to provide a link between those so we can compare the two pieces of data. Similarly, we've got the acute pain still in the yellow terminology, but then we've got something called neuralgia in a different terminology. And the beauty of using a formal infrastructure is that we can do indirect mappings from acute pain to neuralgia. So we can start gathering different types of different levels of data, which is very useful in terms of there are some sites that will collect very specific data, others like acute pain, others that will collect data at the level of neuralgia, and we can actually combine those and compare those for higher level purposes. So what's needed to be done? So for ICNP to be a kind of unifying framework to be able to do this type of inference is, first of all, it has to handle a range of nursing terminologies. So we do produce mappings for different nursing terminologies, and then we have to determine any relationships, any mappings between them. So for example, we have to spot where things are equivalent. So acute pain is the same as a pain that came on suddenly, as in the first example. And then we have to identify entities with more or less detail. So we identify that acute pain and pain are related, and we establish the relationship acute pain is a child of pain, which is called subsumption. So it's, to try to make this a bit more kind of practically focused, we may, a reasonable question at a unit might be, how many times do we on the unit do bladder washouts? And so what would be recorded at the unit level would be bladder washout. We at ICNP would then, through a mapping, map to our concept, which would be irrigating bladder. There may be another question, they're slightly different, using a synonym, how many times do we do bladder irrigations on our unit? And so they would record bladder irrigation through our mapping. We would map also to irrigating bladder, as in the previous example. Then there may be a higher level purpose. How many bladder procedures are we doing within different units? Again, there would be a local term, bladder procedure. Through our mapping, we would have something called performing on bladder, perhaps, which would refer to bladder procedure. And then within ICNP itself, we have the hierarchy represented in the web ontology language. And you can see the hierarchical placement. We have irrigating bladder, and we have performing on bladder. So performing on bladder being a child of performing, irrigating bladder being a child of irrigating. But this doesn't really help us answer our question. We've got the mappings. So, but there's a problem here in that while performing on bladder is a child of performing, we want to be able to gather up irrigating bladder under the higher level concept performing on bladder. And what the use of web ontology language means is that we can use automated reasoning, we can use software to help with the definitions, the formal definitions of concepts to manage the terminology. So before we use the software, this is the original hierarchy, and afterwards you'll see that irrigating bladder is also been classified automatically, nothing that we've done apart from provide the definitions, as a child also of performing on bladder. Quite rightly, we overlook the fact that it should be also a child of performing on bladder, but the software helps us to provide that classification. So, irrigating is a child of performing, both act on the urinary bladder, but we overlook the fact that irrigating bladder should be, logically, formally should be a child of performing on bladder. So we can use software, we need to use software to help to manage this degree of semantic information. So now the result being in this particular example is that we have the two people collecting their data in the language they want to use. We now have a connection between them, we have a mapping between them, we can gather, collect and compare those pieces of data. But we also have a correct classification, which means that we can do the accurate analysis of gathering up all of the bladder procedures, for example, bladder irrigation. So just to sum up what's happening here, what we're doing is we're spotting equivalents such as gallstone and colour biases, and we're also spotting subsumption, for example, acute pain being a child of pain. The other things that we're doing is spotting where there's an error. So where we spot where there's an incorrect classification, such as a mammal being a child of dog, rather than the other way around, and where there's an incorrect equivalence between, for example, cat and dog. So that's as technical as I want to be, and just to sum up my talk, so ICNP is not just a reference terminology. We're looking at using ICNP with both interface properties and with reference properties. So we see ICNP as being used for primary use of clinical data. For example, in terms of facilitating communication, providing a record of care, acting as an aid memoir, all of the things that we traditionally gather data for at the point of care. And for ICNP, we facilitate this through the development of catalogues or subsets of ICNP to bound a set of concepts for use in a particular context. We're also providing mappings to clinical care classification so that people who use clinical care classification at the point of care can actually map to ICNP and then through to SNOMED CT. And we're providing mappings or equivalents between pre-coordinated expressions to SNOMED clinical terms. In terms of the secondary use of clinical data, which the ideal, which this is a model which has some issues because it is a model, it's a generalization. The idea is that you collect fairly granular data at the unit level, and then through a process of aggregation abstraction, you can then use it at the hospital level, again, further abstraction at regional and country level. So examples of secondary use of data, traditional examples are for mortality and morbidity reporting such as through the use of the International Classification of Diseases, for surveillance, for audit, for finance, etc. And what we're doing with ICNP in this regard is you saw how we're using software to help with the hierarchization, and we can produce different hierarchies. We're not confined to a strict mono hierarchy. We can produce different hierarchies to suit different purposes. We're also working with the Belgian nursing minimum data set, which is I'd encourage you to source information around the Belgian nursing minimum data set. It's one of the best examples that I know of the secondary use of nursing data. The information is collected on a quarterly basis, mandated across Belgium, and the information that's collected is used to directly to support hospital financing. I think it covers about 7% of hospital budgets, or influences 7% of hospital budgets across Belgium. And then we're working within the WHO family of international classifications. We're providing the nursing contribution to the international classification of health interventions, which is in its alpha phase at the moment. So as I mentioned before, we're celebrating our 25th anniversary this year through a series of events. We'll also be celebrating again at ICN Congress next year, which will be held in Seoul in Korea. But the next steps for ICNP and for the eHealth program as well is to reassert ICNP as a key component of the global informatics infrastructure. And we can do that, I think. The work with SNOMED CT allows us to make that kind of claim. We'll be continuing the biennial release, so every 2 years, guaranteed, ICNP will be released at conference or congress. We've also committed to providing early releases for commercial partners, for vendors, and for translators, so that they're up and running and ready for release time. We're making translations easier and easier, the process of translation. We rely very heavily on volunteer effort, and we're helping to improve that all the time. We're producing more catalogues to help facilitate implementation. We're finishing off the mapping to SNOMED CT and mapping to other terminologies, and we're continuing to foster commercial partnerships. I'm determined to make ICNP as easy as possible to get hold of, and there's a very simple sign up on the web, on the ICN web pages, that gives you access to ICNP. It's also, there are PDFs of ICNP available on the translations web page of the ICNP pages, which are freely available. And all of the additional things that you might expect around marketing and publication and distribution. So that is all I have time for. I think I'm nearly out of time. I've kind of overrun. I think we wanted more time for questions. But, thank you very much for listening. An hour's a long time to listen to the webinar, and I appreciate your patience.
All right. Thank you, Professor Hardiker, for that very comprehensive discussion. I hope you could give more, just maybe 5 minutes for us to answer the questions which have been posted since 4:30 p.m. From Rowena Gregorio from the Philippines. Could you give us more information on how telehealth nursing is documented?
Sorry, I don't really understand the question.
How telehealth in nursing is documented?
I think it's difficult to provide a general answer to that question, because I think it will be documented in different ways in different countries. One of the barriers, I guess, to the wider adoption of telehealth and telenursing is the lack of standards around this, or the lack of processes, lack of agreed procedures and processes around this. And this manifests most acutely in terms of kind of governance arrangements. So in terms of practice, telehealth obviously allows you to practice in different jurisdictions, and I think we're still away from a distance away from dealing with the governance issues. So the fact that I practice in the UK gives me a right to practice in the UK, but it doesn't necessarily mean that I'm covered to practice through telehealth with a patient in the Philippines, for example. And I think, thinking about documentation, I think this is another manifestation of the kind of slight fog around telehealth. And I think, we're working through the telenursing network on improving that kind of standardization of documentation. So it's a very poor answer to a very good question, but I think that is because there aren't any gold standard models to follow.
All right. Thank you on that. Another, we just run through with our questions from Mia Alcantara. Can you give more information on therapy? Therapy, the one that you discussed a while ago. How can we
Yeah,
get more information on that?
yeah. I think the best thing I can do is if I send you a web link, then perhaps you could distribute that to the participants. Would that be okay?
Right. We could give that when they have answered our email feedback form. Thank you, Professor Hardiker. Let's go to the next. How from Mean Sambat from Cambodia? How is ICNP related to WHO FIC? Please give
Okay.
example and more.
Yeah. So the WHO, as part of its core family of international classification, those classifications are not discipline specific. So there isn't a doctor's terminology in there. So it would be inappropriate for ICNP to be part of the core family because it is a discipline focused terminology. It's focused around nursing, and so there's another kind of accreditation that WHO, a recognition that WHO gives, which is a related classification. So so ICNP is classified as a related classification within the family of international classifications, and what that does is it gets us within the community, and so ICN is providing a kind of nursing voice for the other classifications that are being developed within the family. So ICHI, the International Classification for Health Interventions, being a case in point, currently under development in alpha phase, and ICN are the nursing representation within within ICHI development. And so we'll be meeting in Barcelona next at the network meeting to talk about how to ensure that nursing is represented within what is a general international classification for health interventions. I hope that helps to answer.
Okay. We go to the next. What is the relationship of NIC, NOC with ICNP? Does it support NIC or NIC, NOC, or is it separate?
So NIC, the Nursing Interventions Classification, and NOC, the Nursing Outcomes Classification, are the terminologies as ICNP is. So it doesn't. It's a good question. It wouldn't be appropriate to say does one support the other. They're terminologies in their own right, each with they're different. They have their similarities and they have their differences, and each are good in their own ways. So it's difficult to say how they support each other because it's not really the right question. They exist together. My own views and the views of my colleagues within the ICNP eHealth program is that we're committed to giving nurses the tools that they need to do their job, and that's regardless. We happen to produce ICNP, but if a group of nurses find it beneficial to use another terminology, then we would support and encourage that. The goal is to ensure that nurses have what they need and have the means of contributing information into a global space.
All right. Thank you, Professor Hardiker. On that note, if you have clarifications, please chat it on our chat box. But at the moment, I am just picking up the questions because it's so many. From Shed Mursaleen of Pakistan, do you have collaborative projects in developing countries? And can you quote some examples?
Yeah, well, an example is the ICN has a program of work which is around tuberculosis, and we're so the program is a training of trainers program essentially. So I'm collaborating within that program in terms of looking at the use of mHealth in in developing countries. We're focusing at the moment, we're focusing specifically on a number of wellness centres which are in sub-Saharan Africa. And these are centres that have been established and supported by national nurses associations in other parts of the world. They're centres where nurses and their families can go, or health workers and their families can go for healthcare so that they themselves remain healthy enough to treat the population. And so the eHealth program is actively collaborating with that program in terms of looking at the possibilities for mHealth. You'll appreciate it's a challenge. I know there's a great aspiration for mHealth in many parts of the world, but the infrastructure simply isn't there in some parts of the world. And so we're trying to be as innovative as possible, but we're recognizing the constraints that currently still exist within those countries. So we're looking at a range of technologies from SMS through to more sophisticated smartphones and tablets. The other thing that we're collaborating on is the ICN has a program around which is to deliver libraries, mobile libraries, which are physical libraries, which are placed in places that they don't have access to knowledge. And we're looking at ways of digitizing that library. Again, we're constrained to some extent by the infrastructures in the various places that we'd like to reach. So the places we'd like to reach are the very places that don't have the infrastructure to support what we're trying to do. That there's a position statement in draft coming out of ICN, which is people's right to connect, and we're using that as a vehicle for lobbying governments and other organisations to ensure that people have connectivity, that people have access to the internet, essentially.
Thank you. On that note, we have room for 3 last questions, and thank you for all the questions that you have been posting in our Q&A box. Maybe I will just send the other questions to Professor Hardiker, and we will just respond your questions via email. From Robert Patio, given the lack of standards, how does ICNP plan to approach interoperability from different health systems?
The lack of the standards, in terms of technical standards, there are technical standards to support interoperability, and we're very active in that space. Because we do represent nursing, within the program we feel it's very important that we are active players. We're seen as active contributors within those kind of arenas, and so we've been very closely aligned with the International Standards Organization for Standardization, ISO, for many years now, and so so our contribution is both to provide resources like ICNP, which support interoperability, but also to actively participate in standards development, ensuring that the standards are fit for purpose specifically for nursing.
All right. Down to last two questions. From Art Ongkeko from the Philippines, what do you think are the preliminary concrete steps that the Philippines can take to adopt ICNP as a unifying framework? Can we contribute to the existing terminology database?
One of the things that people have found most useful is to look at existing examples, and the best example is Portugal. They took a decision over 10 years ago, around about 13 years ago. They took a decision because there was a lack of nursing data available, a lack of infrastructure there. They took a decision they looked at a number of options and took a decision to work with ICN and use ICNP on a national level, and they approached their government, and an act of parliament was passed, and so there was both the will to do it, there was the will to do it, but also the mandation. I think it was important to have that kind of endorsement at a higher level. But most importantly was that that nurses within Portugal recognise the need to change. They recognise the need for data and the need for information, and rather than implementing a product and then seeing what comes out of it, I think that kind of desire to change nursing practice is very important. And so, you know, being able to articulate why, to being able to articulate that nursing is an information-intensive occupation. Is, you know, we're knowledge workers first and foremost. We're communication people. We're information conduits before we ever roll our sleeves up and wash our hands. And I think it's important that nurses should recognise that, should embrace it, and as soon as nurses do recognise the need for information, then they start demanding the tools that they need, which are things like ICNP or other terminologies.
All right, for our last question, from Razel Custodio from the Philippines again, one of the postulates in technological competency as caring in nursing theory is technology brings the patient closer to the nurse. Conversely, technology can also increase the gap between the nurse and the nursed. What is your stance on this? Maybe I'm going to type the question also in our chat box so that everyone could view the question.
Yeah, it's right. I think it's true. I think it's true that the reality is, I think that's a very good question. It's very, very well expressed. I think the reality is that it can do both. It can both bring people closer and it can distance people. I think the overall the benefits are that it brings people closer. We have to accept that patients are very engaged with technology at all ages, and in some senses, nurses have been slower to adopt technology within professional practice than the population has done in terms of their own day-to-day life. And I think that technology itself, I think nurses are in a really good position to mediate, if you like, between citizens and information. And I think that in that respect, I think it brings people closer. There are poor examples, and we've seen poor examples where people are looking at a computer screen rather than looking at a patient. But I think overall, my view is that technology will bring people closer, not least because increasingly patients are the drivers of their own health, and it's very important that information is a very important part of that. And that nurses have a role to play, definitely a role to play in mediating, moderating, providing, if you like, technical support for patients as they try to traverse a very complicated information space.
All right. Thank you again, Professor Hardiker, for responding to the questions. We still have many more questions, but I know that you'll be responding via email. Any last words before we end and we say goodbye and give some announcements to our network?
I just like to thank everybody for tolerating me, but also for participating so actively. I think the number of questions belies an energy or an enthusiasm that's within the region, and I think it's refreshing to me. It's very exciting, and I think that you're obviously in a very good, exciting space in terms of informatics and eHealth. So I'd urge you to continue, and anything that we can do to help with any initiatives in the region, please get in touch with me. But thanks for listening. Yeah.
Yes, and we are very privileged to have you in our session this afternoon. Before I end, I would like to thank the 11 countries who are with us this afternoon, our AeHIN friends from Thailand, Philippines, Cambodia, Sri Lanka, Bangladesh, Taiwan, Nepal, Indonesia, Pakistan, and Bhutan. Thank you for coming for our AeHIN Hour. I see you for the new schedule of our AeHIN Hour that is every second Wednesdays and fourth Thursdays of the month, and our time will change because of the by request by our by the members of from countries who meet last July in our Kunming meeting in China. Thank you very much, Professor Hardiker. Would it be okay if they contact you for other questions? Because some are still asking for resources and other contact information about the tools that you have shared a while ago.
Yeah, and feel free to share my email address with participants. So it was on my final slide, but I'm very happy for people to contact me directly. If perhaps it would be helpful if people said that they were on this call, on this webinar, then I can contextualize it.
All right, all right. Again, many thanks. So many thank you for this afternoon. This is Aliyah Evangelista from the Asia eHealth Information Network. See you on our next meeting. That would be fourth Thursday of the month. That is August 20. Last Thursday of the month. That is August 28th. Thank you for staying with us this afternoon.